So thank you very much, and it's great to be here, and thanks to the organizers. I guess they don't want me to see what I've written here, and that's why the lights are shining. So the good news about this is I'm the only one in the room who knows nothing about the cell side. So I can say what I like, and that's fine. So my world is medical devices, safety critical systems in general, just to put it in context. I work in nuclear power, medical devices, automotive, anything where if the software doesn't do what it's supposed to do, we lose lives. So medical devices is a big one for us. If we come down to looking at infusion pumps and insulin pumps, well, the insulin pumps that we have right now, as we've been hearing, they work really well. They don't work perfectly in terms of replacing the pancreas and the beta cells, but they've been working for a long time. And they're getting better. And the reason that they're getting better is that we're actually looking to see how we can give a more natural treatment. So instead of the injection 2 or 3 times a day, as Professor Sefton told you, we now have pumps, and what the pumps will do is you can program a profile so that during the day, for 24 hours, you can predetermine how much insulin should be coming into your body, and when you want more, you get a bolus amount by pressing a button. So that's one way that we've actually improved them. Another way is the so-called artificial pancreas, which is a closed-loop system. So basically what you do in this system is instead of taking a measurement of your glucose manually, you have a device, a sensor that will actually do that for you, and it's tied directly to the pump. So that's the way we're trying to close the loop, and there are already a couple of artificial pancreas on the market. So right now, I think our concern is typically one of safety. The effectiveness, I think we're actually achieving. The safety side is always something that we concentrate on. And safety will also include being more natural so that we don't have the generated side effects of treating the diabetes. When we come to looking at safety, there's some things that I wanted to talk about, completely different from the things that we've been hearing today. And that, first of all, the pump is man-made. And the man-made, in some cases, is going to actually be a benefit to us because we understand it better. I know these people around me understand what's going on in my body a heck of very well, much better than I would like them to. But actually, I think we understand the man-made things even better. And even more than that, there are ways of producing these pumps, for instance, where I know that I've got a predicted output for any combination of inputs. So I've got some determinism in the pump that I'm producing. And that is something that we can't say all the time when we look at cell treatments. I'm not saying that we know how the body behaves every time we pump insulin into it. I'm saying that I know what the pump does. If we start talking about safety, if you go back a few years, there was a very famous engineer, Vincenti, who wrote a book called What Engineers Know and How They Know It. And in this book, he talks about radical versus normal design. Radical design is when you're pushing the envelope. You're using theories, you're using technology that is not mainstream. Normal design is when you're using something that is mainstream and very well known. And guess what? When you come to safety critical systems, the golden rule is stick with normal design. If you go into radical design, that's usually when we have accidents. If I look at what's available to us now, the pumps are normal design. Cell treatment, I think, is still at the radical design stage. The other thing that we look at is complexity. Complexity is something that means a lot to us in the safety world because it usually is an indication that we're not going to manage to put together the intellectual control over the system that we're working with. Now, if you look at the pumps on the market and if you look at the pumps that people are talking about, they've deliberately kept the pumps as simple as possible. And in this particular case, simplicity is a virtue. So even if we don't have a very accurate reading for your blood glucose, we actually do have algorithms to tell us how we should treat the diabetes depending on those readings, and these algorithms are simple. Right now, they're actually manually employed, which I agree is not the greatest way of doing it. So I prick my finger, I get a blood reading, and then I decide what I want from my pump. The idea is that we want to change this and have sensors directly connected to the pumps themselves. One of the other things that we do in pumps that I don't see how we would do in the cell treatment is in the nuclear world some time ago, they discovered how beneficial it is to separate control and safety. So for instance, if you have a nuclear power station, you have the control of the system, but you have a safety system built on top of it that's completely independent, doesn't depend on the control system at all. That's the sort of thing that we're looking at now in terms of medical devices. What are the safety systems that we can put on the medical devices where the only reason for that system's existence is to preserve safety? All of this leads to a defense in depth approach. The medical device world has a great name for it. They call it Swiss cheese. So if you think of slices of Swiss cheese, and what you do is you want to line up the hazards that could go through the Swiss cheese. If you make sure that the hazards don't have a straight path through all of the Swiss cheese. And the last thing that I wanted to talk about was the difference in the cell world and the device world in terms of hazard analysis. So anytime you're putting together a safety device, sorry, I can't get these people to stop calling me. So that's a safety system I didn't think of. So if you look at the hazard analysis that we do every time we put together a safety device, one of the first things we do is we look at the hazards which can cause harm, then we try and work out how to mitigate those hazards. People think that they're doing that in this clinical world as well, but it's different. The difference is that what we tend to concentrate on is the severity of the consequence of the hazard. What's happened in the medical world is they think of risk. Risk is severity of the consequence multiplied by the likelihood of that hazard actually occurring. And that's where things go wrong, because we have a really bad history of actually estimating how often those bad things will happen. If you look at accident scenarios, we always knew that that bad thing could happen, and someone's decided it wasn't likely in that particular case. So what I would suggest is that in terms of safety, the medical devices are there right now. We know how to do it. We're getting better. I'll come back and talk about what I think of the cell world when I've actually heard a little bit more about it. Thanks very much.